In this presentation, we're going to cover the common cancers that can affect the skin and their precursors, the precancers. We classify skin cancers according to their cell of origin. So epithelial skin cancers include the commonest cancer that occurs in men and women, basal cell carcinomas, and also squamous cell carcinomas. So these are the non-melanoma skin cancers. We can see cancers that arise from adnexal structures such as hair follicles, sweat glands and sebaceous glands. Of course, a relatively common and very serious condition is malignant melanoma, which arises from melanocytes in the skin. We can see lymphomas of the skin of both the T and B cell lineage, and we can see tumours that arise from connective tissue such as sarcomas and vascular tumours. And of course we can see metastases in the skin, the commonest cancers to produce skin metastases being lung and breast. Non-melanoma skin cancer and melanoma is an increasing problem, and in this graph here you can see the age standardised incidence rates in the United Kingdom between 1993 and 2018 in 2-year blocks. So there's been a steady increase in incidence during this period of time. So in the UK there are about 150,000 new cases annually for a population of about 70 million. And there are about 1,000 deaths from non-melanoma skin cancer, principally from squamous cell carcinoma. Melanoma too is an increasing problem, again age standardised incidence rates in 2-year blocks, and there's been a trebling of incidence in a 30-year period. And these are the incidence rates per 100,000 population for malignant melanoma stratified by age. So it's an exceedingly rare cancer under the age of 20, but a significant cause of both morbidity and mortality, even in the 20 to 40 year age group. And in the United Kingdom, in 2021, there were 17,000 new cases of malignant melanoma and 2,300 deaths. And the incidence of malignant melanoma increasing is a global problem, with the highest incidence per unit population being in New Zealand, followed by Australia, Oceania, and then the rest of Northern Europe following behind. So firstly we'll cover the precancers of the skin. Squamous cell carcinoma may be preceded by an area of what is called in situ squamous cell carcinoma, a synonym being Bowen's disease. These may be solitary or may be multiple, and they tend to occur on high sun exposure sites, particularly the lower legs, particularly lower legs in women, and the face. The typical clinical characteristics of Bowen's disease are that of a slowly enlarging pink patch or plaque, and as I say, most commonly this tends to occur on the lower leg. It's got a rather irregular edge, and there's usually overlying scale, and it's very easy for it to mimic a patch of psoriasis or eczema, but that irregular margin to the lesion is often one of the clues. And as mentioned, it occurs on sun-exposed sites. Here are two examples of Bowen's disease. In the upper panel you can see that there's a very well marginated scaly plaque which has arisen from around the nail unit. It's slowly spread over a number of years. In the lower panel you can see a very well marginated scaly plaque again, which has been present for at least 10 years, slowly growing on the neck. And of course the problem with in situ squamous cell carcinoma or Bowen's disease is that invasive squamous cell carcinoma can develop within it. That would be recognised by the presence of a lump which suddenly arises within the plaque, and the chances of this occurring is somewhere between 1 in 20 and 1 in 30. So invasive squamous cell carcinoma can arise relatively uncommonly within patches of Bowen's disease. So obviously the aim of treating Bowen's disease is both to treat the cosmetic lesion, but importantly to eradicate the chance of invasive squamous cell carcinoma arising within it. Small areas of Bowen's disease can be excised and then primarily sutured. Larger lesions can be treated by curettage and cautery. Cryotherapy is perhaps not quite as effective as excision or curettage and cautery, but it's quick and convenient. There is a treatment that we can use in Bowen's disease called photodynamic treatment. So a preporphyrin is applied to the lesion and the tumour cells can convert that preporphyrin into a porphyrin. The normal cells cannot. So that when light is then applied to the lesion, the porphyrins which are produced are excited and destroy the affected cells. So this is a treatment that can be used both for Bowen's disease, for actinic keratoses, and also some superficial basal cell carcinomas. That is a clever and neat way of dealing with them. Actinic keratoses, sometimes called solar keratoses, are exceedingly common, and they occur on the light exposed areas and increase in number with age. They occur on the forehead, particularly the bald scalp, the nose, ears, neck, backs of hands, lower legs and feet. They start often as a small pink, very slightly scaly patch, and with time they'll develop rather a sandy and rough feature and may even become quite markedly hyperkeratotic. They're exceedingly common and in a relatively low sun exposure area such as Liverpool in the north of the UK. 1 in 3 men and 1 in 5 women have at least one by the time they are 70. Actinic keratoses may be solitary, but much more commonly multiple lesions will eventually develop. And we call the change where these arise as field actinic change. So in the upper image you can see a bald scalp, so obviously this is a high sun exposure site, and there are lots of these hyperkeratotic rough patches all over the scalp. So this is field change that's occurred all over the bald scalp. Similar changes can occur on the dorsal aspects of the hands. So on the lower panel you can see little scaly patches which are typical of actinic keratoses. Women often have significant actinic damage affecting their feet and lower legs, and that's probably because they like to tan the legs so they don't need to wear tights or stockings in the summer months. So they can get a disproportionate amount of actinic damage in these areas. And you can see on the upper panel lots of little rough scaly patches on the dorsal aspects of the feet. They extend up to just below the knees, and this is all field actinic change with numerous actinic keratoses. Actinic keratoses are very common on the edge of the pinna, and lesions can become quite hyperkeratotic and even develop into what we call a cutaneous horn. So importantly, one must consider, particularly in a lesion like you can see on the lower panel, has invasive squamous cell carcinoma arisen within an actinic keratosis present on the ear. So how do you prevent actinic keratoses? Well, obviously avoid excessive sun exposure. So try and alter behaviour to minimise exposure when the flux from the sun is at its highest. And obviously this is between 10 and 12 in the day. Obviously, if you need to go out, wear a sunscreen, something with an SPF of 30 to 50, stick it on before you go out, replace it every 2 hours. And obviously use clothing that is going to screen the skin, so hats with a brim, clothing that is relatively thick, prevents ultraviolet penetration, and this will also help prevent the development of actinic keratoses. So how do we treat actinic keratoses? Well, obviously, again, the aim of treating actinic keratoses is firstly to reduce their inconvenience and cosmetic burning, but importantly to try and prevent the development of invasive squamous cell carcinoma. Thin lesions may actually resolve with sun protection, and large studies were done in Australia looking at the effect of placebo versus sunscreen on actinic keratoses, and by using sunscreen and sun protection, a proportion will resolve. Obviously, only the thinner ones, the thicker ones, are much less likely to do that. If there are a small number of actinic keratoses, the precancerous cells can be destroyed with liquid nitrogen. Thicker lesions can be submitted to curettage and cautery. Obviously, if there's a concern that a lesion may have progressed from an actinic keratosis to a squamous cell carcinoma, that lesion would require excision. The clue to the development of squamous cell carcinoma is a change in the characteristics of a long-standing lesion. It may become tender, lumpy, indurated, and painful. So these are all important clues that both doctors need to know about, and importantly patients need to know about, so that should that occur, they should seek urgent advice. Large numbers of actinic keratoses that arise within a field change may require topical treatment. The gold standard treatment is 5% fluorouracil cream. So this is a cytostatic cream which is applied to the field defect, usually needs to be used for 30 consecutive days. It can produce quite an irritant reaction, but once this subsides, it can be very effective. There are other treatments available. There is an immune modulator called imiquimod, which basically enhances innate immune responses, and this can be useful for, again, field changes of actinic keratoses. As mentioned previously, photodynamic treatment using a preporphyrin cream followed by the application of usually red light can be useful for field changes. Basal cell carcinomas are exceedingly common. There are about 90,000 diagnosed annually in the United Kingdom, and many may actually go unnoticed. They occur on the face, the lower legs, scalp, trunk and back. Unusually, they're very uncommon on the back of the hand. Squamous cell carcinomas and actinic keratoses are very common there, but basal cell carcinoma is relatively uncommon on the back of the hand. They occur more commonly in the elderly, the fair-skinned, those with red hair, and people who've had a high lifetime cumulative sun exposure, such as outdoor workers, farmers, roofers, builders, etc. Basal cell carcinomas are more common in those who've lived at altitude and again have had outdoor occupations proximal to the equator. So what causes basal cell carcinomas? Well, easily the most important aspect is ultraviolet radiation. So people living in high sun exposure sites at altitude, people whose skin doesn't tan easily, people whose skin burns easily, they're the people who are susceptible to getting basal cell carcinomas. But there are one or two other things that can predispose to basal cell carcinomas. X-ray irradiation, so basal cell carcinomas can arise within the fields of radiotherapy, and many years ago a scalp ringworm used to be treated by X-ray epilation of the hair. Obviously we've got very much better treatments these days, but quite commonly this was then associated with basal cell carcinomas arising many years afterwards. Arsenic predisposes to basal cell carcinomas, and arsenic is present in the water in high levels, particularly in areas where there are very deep wells which are used to extract drinking water Bangladesh being one of the most notorious, and high levels of arsenic ingestion from water can predispose to basal cell carcinomas. Finally, there are a couple of genetic conditions which predispose to basal cell carcinoma. There's the basal cell nevus syndrome, sometimes called Gorlin syndrome, and these individuals will develop numerous basal cell carcinomas, often from relatively early on in life, and it may be associated with a number of other problems, including dental, jaw, and central nervous system problems. Even rarer is a condition called xeroderma pigmentosum. This is a condition where there is a defect of DNA ultraviolet light repair, and this predisposes to multiple basal cell carcinomas, squamous cell carcinomas, and melanomas, again from very early ages, often from the age of 6 or 7. There are a number of subtypes of basal cell carcinoma. The commonest is a nodular cystic basal cell carcinoma. So this will present as a slowly enlarging pink, rather glassy lesion. Again, tends to occur very commonly on the face, scalp, less common on the body. They'll present initially as just a little patch which doesn't seem to really go away. It may fluctuate in its severity, and then people find that they're getting larger, and often then they'll catch them, particularly when they're toweling the skin, and they will ooze and bleed. They're often multiple, so if somebody's got one basal cell carcinoma, it's your duty to check everywhere else, because you might find another, and in fact you might find also another sun-induced skin tumour such as a melanoma elsewhere. So it is important to, having found one, check they haven't got another. If someone develops one basal cell carcinoma, they've got a 15% chance of developing another in the next 5 years in the United Kingdom. So if people get one, they do tend to be susceptible to them. Look elsewhere. So as previously mentioned, the features of a nodular cystic basal cell carcinoma are of either a plaque or a nodule. Ultimately, they develop rather a glassy or pearly appearance, and they've often got coursing over them angulated telangiectatic vessels, and they're often flecks of pigment in the edge of the lesion, so a typical nodular basal cell carcinoma. Another common type of basal cell carcinoma is the superficial basal cell carcinoma. So this will present as a slowly enlarging patch, then plaque. They're often pinkish in colour with a slight overlying crust or scale. One of the clues is they have rather a thready, slightly raised periphery, and again they'll often ooze or weep. So the clue is a slowly enlarging, slightly irregularly marginated, thready edged patch, and the patient is often alerted to these because they'll either itch or they'll find that when they towel their skin it'll ooze and it might bleed onto their clothing, and that's often the sign and clue to the patient that they've got a basal cell carcinoma. Superficial BCCs may be solitary. In the lower image you can see a man who's got numerous basal cell carcinomas, superficial basal cell carcinomas all over his back, and that's because many years previously he had radiation treatment for ankylosing spondylitis. Again, a treatment that's really not used these days. It's been superseded by particularly biological medications. But it's a little bit of dermatological archaeology, radiation-induced multiple superficial basal cell carcinomas. Basal cell carcinomas can ulcerate. Now, basal cell carcinomas really are seldom a cause of mortality, but they can be the result of considerable morbidity, particularly their treatment. Occasionally, people will hide away and neglect their slowly enlarging basal cell carcinomas. So this is a lady who's got a basal cell carcinoma on her scalp. It's probably been present for 20 to 30 years, and she's hidden it under a wig. And you can see centrally the basal cell carcinoma has invaded right down to the skull. And obviously this is a huge management problem now. So basal cell carcinomas ultimately may ulcerate. Occasionally people neglect them. So here's somebody who's got a slowly enlarging plaque which has wept and bled on his medial lower calf. And you can see he's also got varicosities. So it'd be very easy to misdiagnose this as a varicose or venous ulcer. But I think one of the clues is this hasn't got better with appropriate treatment for a venous ulcer with dressings and compression. So any non-healing, slowly enlarging ulcer should be biopsied, because it could be a basal cell carcinoma, it could be a squamous cell carcinoma, it could even be a malignant melanoma. So a non-healing ulcer, consider malignancy and biopsy. Another variant of basal cell carcinoma is the morphic basal cell carcinoma. So these lesions, instead of becoming nodular cystic, become sclerotic and produce an indurated area. But again, they've often got indistinct borders, but look at those telangiectatic vessels which are coursing over the lesion. That's the clue to this being a morphic basal cell carcinoma. The tumour often extends beyond the visible clinical edge, so these are often much larger than you think they might be. Morphic basal cell carcinomas. As mentioned previously, quite commonly you will see little flecks of pigment in the edge of a basal cell carcinoma, but sometimes the pigmentation predominates and the people develop pigmented basal cell carcinomas, and these can mimic malignant melanoma. Obviously they have a much better prognosis, but again, look at the site, typical site for basal cell carcinoma, rolled edge. If you look carefully, you might see underneath the pigment the telangiectatic vessels, but the pigment is predominating. How do basal cell carcinomas behave? Well, they virtually never metastasize. They slowly grow, probably about 1 millimetre every 3 months. The problem is they can be locally destructive, so they can invade through the dermis into the fat, muscle, bone, cartilage, and importantly they can extend into vital areas such as the orbit and the external auditory canal and ear. So although they grow very slowly, particularly with vital structures, they can invade and produce problems. We can stratify basal cell carcinomas into high and low risk disease. So low risk areas for basal cell carcinomas are the hand, where actually they rarely develop, on the arm, leg, trunk, thorax, and on areas of the face away from the central T-zone. The T-zone being comprised by the eyes and the nose. The high risk areas particularly are areas of embryological fusion, because the basal cell carcinoma can track down these embryological fusion lines and invade quite deeply. So this is areas particularly on the face, so the lid, the nose, lips and around the ears. They can extend relatively easily, so these are high risk areas. The vast majority of basal cell carcinomas merit therapy, but occasionally low risk lesions in very elderly patients, it may be reasonable to leave it, particularly if it's growing very slowly and producing minimal symptoms. Other options available would be as follows. Ideally, excision of the lesion and primary closure or skin grafting. Less effective in terms of cure rates, but quick and easy to do, is a treatment called curettage and cautery. Specialised surgical treatments such as Mohs micrographic surgery can be undertaken for complex lesions. So this is when the skin cancer is excised, and during the operative period the margins of the tumour are examined under frozen section to see that the tumour is completely excised. If it's not, then a further excision can be done until the margins are clear, and then the defect can be reconstructed. Radiotherapy is an option. It's often favoured by older patients. Cure rates can be as good as surgery. Ultimately, the cosmetic result tends not to be as good as surgery because radiotherapy will leave a white mark, often visible after a year or two post-treatment. Superficial lesions can be treated by photodynamic therapy, as we mentioned before, and then we can use topical immunotherapy, again for thin superficial basal cell carcinomas. So just to summarise, larger nodular cystic lesions, surgery or radiotherapy are options. Superficial basal cell carcinomas, topical treatment with immunotherapy, photodynamic treatment, or curettage and cautery. So what are the merits of different treatments? Well, excision tends to be relatively slow, but gives you histological material for tumour margins to make certain it's been completely excised. Lesions tend to be excised with a 2 to 3 millimetre excision margins, and this will produce a low recurrence rate of under 2% and tends to give ultimately good cosmesis. Obviously, after excision, the defect needs to be repaired either by primary closure, a flap procedure, or graft reconstruction. Curettage tends to be a quick procedure. It requires the lesion to be double curetted, so local anaesthetic, curette the lesion, cauterize it, curette again, cauterize, and then put a dressing on. Areas tend to heal relatively slowly, and of course you don't get margin control with histology as you might do with an excision. There's often an ultimate reasonable cosmesis with variable recurrence rates of anywhere between 10 and 20%. So curettage and cautery is for low-risk sites only. Liquid nitrogen cryotherapy is quite a quick procedure, and here you can see liquid nitrogen being sprayed onto superficial basal cell carcinoma on the arm. It's quite painful, and a relatively long double freeze cycle is required. Again, there's a relatively long healing time. Cosmetic result is reasonable. Again, only for low risk and superficial basal cell carcinomas. Radiotherapy may suit those who are terrified of surgery. It does require 4 or 5 visits as the radiotherapy dose is fractionated, has a good response, low recurrence rates, similar to those of excisional surgery. Now, early on you get excellent cosmetic results, but as previously mentioned, as time goes on, there's often a white area that develops in the field that's been irradiated. Mohs micrographic surgery, so this is 3-dimensional frozen section margin control, very useful for high-risk tumours and recurrent tumours. Ensures that the complete tumour is excised, and again with minimal loss of normal tissue, so it's quite a controlled process whereby only the areas where the tumour is still present can be identified and excised. But it's an all-day affair, sometimes a 2-day affair, but it has the best and lowest rates of recurrence. Here you can see photodynamic treatment in process. So the porphyrin precursor is being applied for the tumour, left in place for 2 hours, and obviously the tumour cells can metabolize the pre-porphyrin into active photosensitizing porphyrin, and then the area is irradiated with red light. During the radiation there can be some pain. It's suitable only for superficial basal cell carcinoma, but it does give a good cosmetic result. And again, can be used to treat Bowen's disease, and also can be used to treat field areas of actinic keratosis, so PDT. Obviously, prevention is an important aspect of basal cell carcinomas, and essentially what we need to do is alter the sun behaviour of the risk population. So particularly farmers, builders, sports enthusiasts, they should be encouraged to cover up and use high protection sunscreens regularly from the beginning of their careers, particularly farmers and builders. Obviously we need to alter the tan craving attitude of people, and obviously sun protection, brimmed hats, sunscreens, as we've mentioned. Obviously early recognition is important so that the lesions are small and can be completely excised with little loss of normal tissue, and that'll give you a good cosmetic result. Squamous cell carcinomas are the second most common type of non-melanoma skin cancer. There are about 25,000 squamous cell carcinomas annually in the United Kingdom, and about 600 deaths. Deaths tend to occur in poor prognosis, large lesions that are in excess of 2 centimetres in diameter of presentation, large lesions which occur on the scalp, on the ear and the lip are all relatively poor prognosis. People who are heavily immunosuppressed, so people who've got autoimmune conditions, particularly transplant recipients, they're at a much greater risk of squamous cell carcinoma, and when squamous cell carcinoma arises within them, it does tend to have a worse prognosis. Squamous cell carcinoma can metastasize, unlike basal cell carcinomas, to both the local lymph nodes and to distant viscera. Again, the most common cause etiologically of squamous cell carcinoma is ultraviolet radiation. It can occur after X irradiation, just as can basal cell carcinomas. Squamous cell carcinomas can arise within chronic ulcers and after trauma, I think particularly burns. Again, arsenic exposure from the water can predispose to squamous cell carcinoma. Hydrocarbons, historically, chimney sweeps could develop scrotal squamous cell carcinomas from exposure to hydrocarbons in the soot that they were sweeping. As mentioned previously, those who are chronically immunosuppressed, particularly post-transplant, are at risk of squamous cell carcinoma, particularly when they've got skin co-infection with human papillomavirus. Again, genetic conditions can predispose to squamous cell carcinoma, particularly xeroderma pigmentosum. Unfortunately, mortality of squamous cell carcinoma of the skin is quite high in some of the African countries, and this is particularly due to poor access to treatment, neglect, particularly in the albino population. So squamous cell carcinomas can arise due to an absence of pigment in albinism. Invasive squamous cell carcinoma most commonly will present as a slowly enlarging, tender, indurated nodule, again on a light exposed area, and it's often got a hyperkeratotic cap. More poorly differentiated lesions might present as a proud, weeping, eroded tumour, which might develop a crust on top of it due to oozing and bleeding. The upper image here is taken from someone who's a heart transplant recipient who's on immunosuppression, and he's just developed this slowly enlarging, weeping, ulcerated plaque on the finger. The lower panel shows somebody who's got a chronic varicose ulcer, but its characteristics have changed. The central areas become proud, the areas have become heaped up, it's got a rolled edge and it's tender, and biopsy unfortunately showed the presence of invasive squamous cell carcinoma within a chronic venous ulcer, sometimes called a Marjolin's ulcer. The upper image here is of a patient who's developed a red oozing tumour on the scrotum. This man's had chronic plaque psoriasis and received a type of phototherapy called PUVA for many years, and this has predisposed him to cancers. These days, people undertaking phototherapy always keep their underpants on to protect their genital skin. The lower image shows a chronic ulcerated tumour which feels indurated on palpation. This was a pipe smoking mariner, so chronic irritation from smoking, particularly pipe smoking, can predispose to squamous cell carcinoma on the lower lip. What are the treatment options for squamous cell carcinomas? Well, they're very much fewer than there are for basal cell carcinomas, because we really do need to go for cure because of the propensity of the tumour to metastasize. So anybody who's got a squamous cell carcinoma, check for lymphadenopathy, check for the presence of other tumours, particularly in those who are high-risk immunocompromised patients. Squamous cell carcinomas should be excised with 5mm excision margins. Radiotherapy is also an option for squamous cell carcinomas. For metastatic disease, there are now a number of therapy options, of course none of which are curative, but might improve quality of life and extend life. One lesion which can mimic a squamous cell carcinoma, and in fact some people believe that it is a variant of squamous cell carcinoma, is something called a keratoacanthoma. The clue to this is that a nodular lesion develops rapidly on sun-damaged skin. The lesions have often got rounded shoulders and characteristically have this central, almost volcano-like plug of keratin in the middle. The histology can be very similar to that of a squamous cell carcinoma, but it's known from past experience that if these lesions are left, they may ultimately spontaneously resolve, but tend to leave quite a deep scar. So they tend to be treated, which ultimately gives a better cosmetic result, and they can be treated either by excision or curettage and cautery. Malignant melanoma is probably the most important skin cancer because it's relatively common and does have a significant mortality. So over 17,000 cases of malignant melanoma annually in the UK, now over 2,000 deaths a year in the UK. Melanoma is more common in women, but women tend to present earlier and have a death rate that is lower than that of men. Melanoma can occur anywhere, but it tends to occur most commonly on the lower legs in women and on the back in men. And because men develop on the back, they're often missed, and that's why they tend to present late. And although it's less common than it is in women, presenting late leads to a poor prognosis, and that's why the death rate in men is higher than that of women. So what are the causes of malignant melanoma? Ultraviolet light is very important, but the relationship is fairly complex. The world capital for malignant melanoma is both Brisbane and now the North Island of New Zealand, where they're fair-skinned individuals who often are interested in outdoor lifestyle, living close to the equator. Acute bout exposure, so that is 2 or 3 sunny holidays a year, may be important in people living in the northern hemisphere. Childhood exposure to ultraviolet light is important. So people who've migrated from the UK to Australia in childhood develop a melanoma rate similar to that of the indigenous Australian population. Older children and adults tend to retain lower rates similar to those of the United Kingdom. So that's one of the reasons that we need to think carefully about photoprotecting children, because sunshine exposure in children may be disproportionately important. Mole numbers and types of nevi may be important in predisposing some individuals to melanoma. So babies born with giant congenital nevi have a greatly increased risk of malignant melanoma. Something like 20% of children who are born with a giant nevus will develop melanoma within it during their lifetime. People have got lots of moles that are unusual in their appearance, so they often tend to be asymmetric, have irregular margins with a small nodular area in the centre that looks a little bit like a fried egg. These are called atypical nevi, and if people have got lots of atypical nevi, particularly if there's a family history of malignant melanoma, they have an increased risk of melanoma too. There are various genetic markers, none of which are currently used in clinical practice and at the moment are research tools only. So how does one recognise a malignant melanoma? Well, most malignant melanomas are pigmented, and patients will present with a changing melanocytic nevus. The mole may be A, asymmetric, B, have an irregular or notched border. The colour, they will not be monochrome, they tend to be irregularly pigmented, and there may be black, grey, white, blue and red, all within one lesion. Melanomas at presentation are usually, not exclusively, greater than 6 millimeters in diameter. As mentioned previously, patients have noticed they are evolving. The lesion is increasing in size, it's changing and may be symptomatic. The lesion might be firm, but importantly, it's evolving and growing. So these are the A, B, C, D, E, F, G signs that help in the diagnosis of malignant melanoma. There are a number of types of melanoma. The commonest is called superficial spreading malignant melanoma. So this is a lady who's got a lesion on her leg. She's noticed it's increasing in size. It's becoming irregular in its outline. There's irregular pigmentation, so you can see there's black, brown, grey. The area, the edge is notched. It's asymmetric, and actually in the centre, there's a grey area where you can see there is almost regression of the melanoma. So these are all features of a superficial spreading malignant melanoma. Here's some other superficial spreading malignant melanomas. Again, in the upper image, you can see there's an irregular edge, there's irregular pigmentation. The lesion is reported to be enlarging by the patient. It's more than 6 millimeters in size. In the lower panel, again, it's on a scalp, a irregularly marginated, irregularly pigmented lesion, which the patient has noticed is altering and changing. Both superficial spreading malignant melanomas. This is the second most common variant of melanoma, a nodular melanoma. So you can see a nodule that's actually probably arisen from a flatter black lesion on the forehead. So this melanoma has entered what's called the vertical growth phase, so it's growing vertically. You can see that the peripheral lesion is very dark, but the central nodular area is both black and red. So there's been lots of pigmentation in the most rapidly progressive area. The pigmentation may be lost completely sometimes in nodular melanomas, so they present as a red nodule a so-called amelanotic malignant melanoma. Here's another malignant melanoma. So you can see that it's inflamed, it's actually ulcerated, it's pigmented, there's central ulceration and regression. So this was a rapidly progressive nodular malignant melanoma. There is a precursor to invasive melanoma called lentigo maligna. So this tends to occur on the sun-exposed areas of elderly people, so face, arm are the commonest sites. And there's a slowly enlarging, irregularly marginated, irregularly pigmented lesion, which may become quite large, 4 or 5 centimetres in diameter. Lentigo maligna is an in situ melanoma, so the malignancy has not progressed through the basement membrane zone. It is still only within the epidermis, and as long as it stays there, it doesn't have metastatic potential. But invasive melanoma can develop within lentigo maligna, and obviously then it has the propensity to metastasize. So in the upper panel you can see a typical irregularly marginated pigmented lesion on an elderly person's face, but actually at the top there's a little nodule, and that's nodular melanoma that's arisen within it. Similarly, in the lower panel, a large irregularly pigmented lesion with a nodule which is slightly crusted, which has developed within it. So these are melanomas that have arisen within lentigo maligna melanoma. Melanoma can arise on the palms and soles, and it is often termed an acral lentiginous melanoma. Now, these are relatively uncommon, but are the commonest type of melanomas to occur, particularly in people with skin of colour. The clue is an enlarging patch on the palmar sole, irregularly marginated, notched, irregularly pigmented. These are the clues to an acral lentiginous melanoma. Melanoma can arise from the melanocytes in the proximal nail fold, the nail matrix, and they tend to present with the development of an irregularly marginated and irregularly coloured pigmented band affecting the nail plate. As the melanoma progresses, there is often then dystrophy and destruction of the nail plate. So you can see in the upper panel there's an irregularly pigmented band, and in the centre of the nail there's destruction of the nail plate. So these are all features of malignant melanoma. On the lower panel you can see again an irregularly pigmented area, and there's been destruction and bleeding of the nail plate. You can also see there's pigmentation in the lower panel around the nail fold, and this is called Hutchinson's sign. Melanoma has many mimics. So ordinary nevi can mimic melanoma. Obviously they tend to be regular in their colour, there's no irregularity of the edge, and the lesions tend to be static. Seborrheic keratoses have a stuck-on, thimble-like pitted surface, and small white horn cysts may be visible within them. Here's a young man who's got multiple atypical nevi. So all of his nevi are relatively large, slightly irregular in their outline and pigmentation, and he is at increased risk of melanoma. In fact, since this image was taken, which is now over 20 years ago, he's developed 2 malignant melanomas. So obviously we keep him, and have done, under surveillance for identification of changing nevi. We often see angiokeratomas presenting as query malignant melanomas. But if you look at these very carefully and also look at them with a dermatoscope, you can see that these are lobulated lesions, and the lobules have a very purple appearance. And these are very reassuring and characteristic of angiokeratomas. Dermatofibromas, which are discussed in detail in the benign skin lesions talk, are very common, but it's not uncommon for them to pigment quite deeply, but they've often got a white central area, and when you pinch them they tend to dip under the skin, the positive pinch sign. The lower image is somebody presented with a recent onset pigmented lesion on his abdomen, but if you look at this carefully you can see there are legs on it, and it's actually an engorged tick. So how should suspect melanoma be managed? Well, they need to be referred urgently, and wherever possible, if there's a suspicion of melanoma, the lesion should be excised rather than a portion of the lesion being biopsied. Ideally, the whole thing should be excised for histological assessment. We try and avoid doing incisional biopsies because of the problem of sampling error. Obviously, it's important to assess the rest of the moles. If somebody's got one melanoma, you might find a second. Of course, you might also find other features of sun-induced tumours, such as basal and squamous cell carcinomas. Obviously, one needs to assess for local lymphadenopathy and general examination for visceral enlargement. Obviously, inquire about a family history of malignant melanoma and sun exposure. The prognosis of primary cutaneous melanoma is determined by the Breslow thickness of the melanoma, and this is the distance between the granular layer of the epidermis and the bottom of the melanoma cells, and it's measured in millimeters. So lesions which are less than 0.76 of a millimetre have a 5-year survival of over 90%. 0.76 to 1.49 millimetres, the 5-year survival is between 80 and 95%. Thicker melanomas, 1.5 to 4, the 5-year survival is about 60%. And when the lesions are greater than 4 millimetres, the 5-year survival for melanoma is about 50%. If there's evidence of lymph node involvement clinically, then the 5-year survival drops to 30 or 40%. So this demonstrates the prognostic benefit of early diagnosis. The management of primary malignant melanoma is adequate excision. So in situ melanomas are excised with 2 to 3 millimetres. Invasive melanoma, the excision margins will be dependent upon the Breslow thickness. So lesions which are less than a millimetre in Breslow thickness will need 1 centimetre excision margins down through fat to fascia. Thicker lesions may require 2 centimetre excision margins, and therefore post-operatively, post-excision, people may need either primary suture to close the wound or might need a flap or a skin graft. Sentinel node biopsy is offered to people whose lesions are generally in excess of 1 millimetre Breslow thickness. So in this procedure, the sentinel draining node adjacent to the malignant melanoma, in the basin closest to the melanoma, is identified and examined histologically. If that node is affected, then the patients are offered a lymphadenectomy. Sentinel node biopsy at the moment is conjecture as to whether it actually improves outcomes, but it certainly gives prognostic information. Of course, melanoma may metastasize, so we might see progressive melanoma which produces localized recurrent disease, we can see what's called in-transit disease, and that is the development of deposits of melanoma between the site of the primary lesion and the local lymph node basin. Obviously, you can see metastatic melanoma in lymph nodes, and then distant metastases can occur just about anywhere, liver, lung, brain being relatively common sites. Mercifully for progressive melanoma, in the last 7 or 8 years, there's been an explosion of targeted therapies. So these are things like BRAF inhibitors and immune checkpoint inhibitors, and these are at last giving hope to people who've got metastatic melanoma. Prevention of melanoma is obviously important. Obviously this involves altering people's sun exposure habits, but importantly it also involves mass education to warn people regarding the early warning signs of malignant melanoma. And obviously this is particularly important when people have got multiple atypical nevi. So these people are often under regular surveillance to try and identify the progression to early melanoma. Finally, we move on to skin lymphomas, which are relatively rare. They may be of many cell lineages, but the most common is a cutaneous T-cell lymphoma, otherwise called mycosis fungoides. B-cell lymphomas are less common, and as I say, other types of lymphoma do occur, including natural killer cell lymphomas, but they're very rare in a very specialist area. So how does cutaneous T-cell lymphoma present? It's usually a very slowly evolving disease, and 80% of people who develop CTCL, the lesions are confined as patches and plaques to the skin. They tend to start as very well circumscribed, slightly irregularly marginated, asymmetric patches on the skin. So there'll be patch stage first, then may develop into plaques, and occasionally later nodules can develop within the lymphoma. The upper image shows tumour stage cutaneous T-cell lymphoma. So this man's had scaly patches on his body and face for about 20 years, and then these plaques and then tumours have developed, and they can occur anywhere on the skin. This chap obviously is developed on the face. The lower image shows rather gross, very unusual tumour stage cutaneous T-cell lymphoma. And of course, with disease of this degree, it may progress on to pretty nodal and visceral disease. And lastly, B-cell lymphomas. These tend to present as nodules, often red or purple in colour, and often they're really only diagnosed once they've been biopsied. It's not uncommon for B-cell lymphoma to occur on the scalp, and it may also be associated with alopecia. Cutaneous T-cell lymphoma is often treated symptomatically, particularly if it remains confined in the patch stage, with moisturizers, topical steroids to help itch, and phototherapy. More advanced disease may require total body electron beam radiotherapy or specialized forms of immunotherapy, which are now available. B-cell lymphomas tend to require treatment with radiotherapy and chemotherapy. So there's a brief outline of the common and less common types of cutaneous malignancies.